In recent years, it's quite common to treat depression with compounds different from the usual antidepressants that we have used for about 50 years. In this presentation, we will focus on antipsychotics. In psychiatry, we have more than 100 compounds: antidepressants, antipsychotics, mood stabilizers, benzodiazepines, and sometimes it's difficult to choose which ones to use for each specific patient. But it's very important to know the specific profile of each of the compound that we are using in order to avoid problems of tolerance or problems of compliance, and in general to improve efficacy. Focusing on antipsychotics, we know that antipsychotics were developed since more than 50 years ago, initially for schizophrenia, and here the name antipsychotic. But recently, during the last 15-20 years, they've been widely used in other situations that are not related to the psychotic symptoms themselves. For example, in depression, that we will focus in the present discussion, but also in personality disorders, and also in other situations like the elderly, for example. In this presentation, we will focus on the use of antipsychotics in depression. This is a quite difficult issue because not all of them are appropriate for using in depressed subjects, and the differences among the available antipsychotics are quite wide, and so it's quite important to know exactly which one to use for each specific clinical situation. For example, starting from typical antipsychotics, the first that were discovered many years ago, you can see from the slides that no one of them has a specific indication for treating depression or bipolar depression. And indeed, no one of us clinicians would ever think to use, for example, haloperidol, that is a powerful blocker of the dopamine D2 receptor in depressed patients, because there is strong evidence that if you use single and specific blockade of the dopamine D2 receptor in depression, you have a worsening of depression. This is why haloperidol, for example, is not used for treating depression. On the other hand, atypical antipsychotics, or the most recent antipsychotics, are quite used for depression, both bipolar depression and unipolar depression. As you can see from the approved indication in this slide, some of them are indeed indicated from the label of the compound. Probably the first that was used quite widely for treating depression was quetiapine, that, as you can see, as indeed indication for treatment of the acute and chronic phase of both schizophrenia, bipolar disorder, but also for as a complement antidepressant in resistant depression. But this is something that we all know very well. During this presentation, I will focus on the last three antipsychotics that you can see from this slide, that are probably the newest and the ones that we need more information to know exactly when to use: lurasidone, cariprazine, and brexpiprazole. Obviously, the starting point is the knowledge of the indication of each specific compound. If in the label is written that we can use a specific compound in depression, then of course we have the possibility to use it. But to understand more in detail maybe the subtle differences that are existing across compounds, it's very useful to know how they work, the pharmacodynamic profile. From this slide that is taken from the famous book of Stahl, you can see that our commonly used antipsychotics have indeed a quite a large range of action. They act on a high number of receptors and transporters. Given some specific information, for example, we can start to understand that the antidepressant action of the new antipsychotics is mainly linked to the modulation of the serotonin system. Some of them indeed block the serotonin transporter as well as the antidepressant, but mainly they have an action on the serotonin receptor, particularly serotonin 2A, and this is a quite important effect in terms of improving the mood of the subject. On the other hand, the antimanic action is mainly linked to the dopaminergic blockade we mentioned before haloperidol. Haloperidol is indeed blocking only the dopamine D2 receptor, and this is why it's so effective for treating activation like mania or agitated schizophrenia, but at the price of inducing depression. This is why the new antipsychotic have a combined effect on the dopamine D2 and serotonin 2A, and in this way you have a reduced depressogenic effect and a modulation, a more subtle modulation. And depending on the balance between the blockade of the dopamine D2 and the action on the serotonin receptor, you can have differences across compounds having more or less antidepressant effect. And then, considering all the other receptors, we know that effect on the muscarinic and histaminergic receptor, for example, are the ones responsible for increase in appetite and metabolic effect of the compounds. And in fact, going a little bit more in detail, if we focus on the 4 pines, clozapine, olanzapine, quetiapine, and asenapine, we see indeed that the effect and affinity of the serotonin 2A receptor is much higher compared to the affinity of the dopamine D2 receptor, as you can see from this image, always from the book of Stahl. And this explains why all of them has indeed more antidepressant effect compared to the other compounds that have a different balance of the affinity of the receptors. And these are indeed the dones, risperidone, paliperidone, ziprasidone, iloperidone, and lurasidone, where the affinity of the serotonin 2A receptor is much similar to the one of the dopamine D2 receptor. This is why traditionally those compounds are less indicated in the use of depression. Different is the situation for the ones that have partial affinity for the dopamine D2. Ripiprazole, brexpiprazole, and cariprazine, they have more affinity for the dopamine D2 receptor compared to the serotonin 2A receptor, but this is a partial affinity. And this explains why those have indeed some kind of antidepressant effect, because they don't block completely the dopamine D2 receptor. And so they don't deplete completely dopamine from the brain of our patient. And this modulating, fine modulatory effect on dopamine and serotonin is indeed the basis of their antidepressant effect. But in the previous slides, we saw the example of the serotonin 2A receptor. But as you can imagine, there are many receptors, as you remember from the first slides. And therefore, the combination of all the effects is indeed quite complex. Just to make another final example, this is the serotonin 1A receptor. This is also important in terms of antidepressant action because it modulates the availability of serotonin in the synapses. And also in this case, as you can see, clozapine, olanzapine, quetiapine, and asenapine have indeed slightly more affinity for the serotonin 1A compared to D2. And this is the opposite for the dones, risperidone, paliperidone, and so on. And this also contributes to the higher effect, antidepressant effect of the pines compared to the dones. But these are just examples to give you the idea of how complex is the pharmacodynamic of these new antipsychotics, because they indeed affect a large number of receptors and transporters. But it's a starting point for understanding the subtle differences that are there across compounds. And so it may help us choose the good compound for each patient when we want to achieve a better efficacy and tolerability. So from now on, we will focus on the 3 new antipsychotics that can be used in case of depression, that are cariprazine, brexpiprazole, and so let's start with cariprazine. Cariprazine is quite an interesting antipsychotic because, as you can see from the slide from the style, we have a partial dopaminergic action on the dopamine receptor D2 and D3. And we have an effect on serotonin 2A, partial on the 1A and 2B, and a little bit on the histaminergic one. So from the previous slides, you can start to understand that probably cariprazine may have some kind of antidepressant effect, and so there could be a use in depression. But let's see this a little bit more in detail in the next slide. Given that we are very interested in understanding the specificity of each available compound, a few years ago we made this focus on cariprazine, and we tried to understand which are the patients that most benefit from the treatment with cariprazine. And what we have found. Let's start from the general effect of cariprazine. Talking in terms of general antipsychotic effect, we can see from the meta-analysis that we performed that indeed the effect of cariprazine on the global psychosis picture is not that strong. Of course, as you can expect, clozapine is the strongest antipsychotic that we have, and then the usual ones that we use are olanzapine, risperidone, and paliperidone. Compared to them, cariprazine is not that effective, is not a very strong antipsychotic. So this is the first indication that we can have, is some kind, we can consider it as a delicate effect, not a very strong and hard effect on the brain chemistry. And indeed, this is quite evident, particularly in the effect on positive symptoms. Compared to the other compound, we see that both low and high dose of cariprazine is not exceedingly effective in treating positive symptoms. But the effect that we defined as a delicate effect, not that strong on positive symptoms, is a positive aspect when we focus on negative symptoms. And indeed, as you can see in this slide, if we analyze the benefit of cariprazine on negative symptomatology, we see that both low and high doses have a relevant effect on negative symptoms, more than other antipsychotics. And this gives the first message, the first take-home message of this presentation, that cariprazine is indeed more effective on negative symptoms than on positive symptoms. Therefore, we can think about cariprazine on those patients that are mainly with negative symptomatology, with prevalent retirement or inhibition, compared to patients that are quite agitated. And we are talking about schizophrenia. But this can be useful also in depression, as we will see in the next slides. And indeed, if we compare cariprazine with risperidone, that is not considered a compound that is inducing negative symptoms, because risperidone is also effective on the serotonin 2A, and therefore it is balancing the effect of the dopamine D2 blockade. But being that cariprazine is a partial agonist of dopamine D2 and D3 and acting on the serotonin receptors, we can see that the effect on negative symptoms is generally better compared to other compounds. But this is not the case for positive symptoms, as you can see here. We will see in the presentation some slides that are taken from the CANMAT, the Canadian Network for Mood and Anxiety Treatments, that are very useful from a clinical point of view. And indeed, these guidelines, as you can see, put cariprazine with full evidence for treating acute depression in the case of bipolar disorder, and with level 1 evidence, of course, is on second-line treatment compared to quetiapine and lurasidone that we will see later. Efficacy must be weighted also versus tolerability. And we can see here that cariprazine indeed is quite well tolerated. So as we discussed before, we should consider cariprazine as somehow a delicate treatment, very well tolerated, not extremely strong in terms of antipsychotic effect, but with a relevant effect in bipolar depression. And this effect in bipolar depression is quite clear. As you can see from these results, you can see a separation from placebo since the first and second week of treatment. And this result is now considered accepted also because it's been confirmed, as you can see, even more recently in independent studies. But if cariprazine is definitely useful in bipolar depression, can we use cariprazine also in unipolar depression? There was some evidence of this, well, not a very strong effect, but you can see an effect of cariprazine in second and fourth week of treatment in subjects with inadequate response to antidepressants. But these results have not been consistently replicated. So I would say that at present we cannot suggest the use of cariprazine in the case of unipolar depression. While in unipolar depression, probably we have much more interest in using brexpiprazole. Brexpiprazole, as you can see, is a little bit different from cariprazine because there is a stronger effect on the serotonin receptor and a reduced effect on the dopamine receptors. You can see there is the same partial affinity for the dopamine D2, but much less for the dopamine D3. And this probably explains why brexpiprazole, from the clinical evidence, has a more clear antidepressant effect also in major depression. And indeed, since the first reports, evidence is accumulating that brexpiprazole is effective also in major depressive disorder. Interestingly, you can see that all the evidence is in the same direction, that the combination of antidepressant plus brexpiprazole is more effective compared to placebo. Indeed, if you want to see a little bit more detailed description about the specificity of brexpiprazole, you can see this paper that recently has appeared on Expert Opinion on Pharmacotherapy, where I make the point that brexpiprazole is indeed different also from aripiprazole because of different pharmacodynamic effect. Is a little bit more sedative, and probably also because of some efficacy in terms of inflammation, as demonstrated in the animal model, can be considered more effective in terms of antidepressant effect. But as I say, no benefit comes without a price, and so the tolerability of brexpiprazole in some specific domains is less than aripiprazole in terms, for example, of weight gain. And therefore, we would never suggest brexpiprazole in patients that are already lethargic, where aripiprazole is more stimulating. So we have seen cariprazine that has a good indication for bipolar depression and negative symptoms in schizophrenia. We have seen brexpiprazole that has good antidepressant and anti-anxiety effect, more compared to aripiprazole and compared to cariprazine. And now we see the third and last compound, lurasidone. As you can see, lurasidone has a basic difference compared to the previous two compounds because it is a full antagonist of the dopamine D2 receptor, and therefore, as you can imagine from our previous slides, it has a reduced effect in terms of antidepressant efficacy. But still we have a relevant serotonin 2A and 1A affinity, and therefore there is some antidepressant effect, but probably in different subgroup of subjects, as we will see later. In fact, the CANMAT guideline put lurasidone as a first-line treatment as well as quetiapine with level 1 evidence for the acute depression in bipolar disorder. And lurasidone as well is quite well tolerated, as you can see from the analysis of the same guidelines. Therefore, we have good evidence that lurasidone is indeed effective in schizophrenia in the left part of the slide and in bipolar 1 depression. But not only in general in bipolar depression. As you can see from this very recent study, lurasidone showed more effectiveness in patients that have a mixed depression measured by the Young Mania Rating Scale. And so, going to the end of this presentation, I recommend you this review where we summarized the information that was discussed in the previous slides, and we focused on the specificity profile of lurasidone, brexpiprazole, cariprazine, and some aspects also of a new one, lumateperone. And in that review, you see this summary table that is exactly what I was suggesting before, the connection between the pharmacodynamic profile of each compound and the specific subgroup of patients that is more benefiting from the specific compound. For example, starting from the top, you see that the specific profile of lurasidone that is acting on the serotonin receptor in a complete or partial way, depending on which receptor, and in a complete way antagonist of the dopamine D2 receptor, then we have indication, a clear indication for schizophrenia and for bipolar depression, particularly in mixed bipolar depression, but not in unipolar depression. While brexpiprazole, with this different profile of partial agonism on the dopamine D2, has indeed received indication for adjunctive treatment in major depressive disorder, with a specific efficacy in those patients who are more anxious or irritable because of the sedative effect. And finally, cariprazine indication for schizophrenia or mixed bipolar disorder with a specific indication in the subjects with negative symptoms. And so we have seen why it is important to have in mind which is the specific pharmacodynamic profile of the compounds that we are prescribing every day when we have a more antidopaminergic or serotoninergic modulating effect or muscarinics and so on. And this is reflected in the approved indications. In this table, we summarized the US FDA and European EMA, but also in terms of the tolerability and the side effects. And therefore, it's not surprising that lurasidone with the dopaminergic activity may give a little bit more compared to other akathisia and neurological side effects, while brexpiprazole, due to its specific anti-anxiety effect, may lead to a little bit of weight gain in certain subjects, and cariprazine also, due to the dopaminergic profile, some extrapyramidal symptoms and akathisia. The knowledge of the specific profile of each compound is useful for a targeted treatment. What I would like to suggest is to avoid polytherapy. This is a prescription, an example of prescription. It is in Italian, but you can easily understand that, in my opinion, should be avoided when possible. Some patients maybe may need a combination of treatment, but when you prescribe, as in this case, to the same patient, aripiprazole, clomipramine, benzodiazepines, venlafaxine, lurasidone, lithium, and trazodone, then it's quite difficult to understand which is the specific efficacy of each of the compound that we are prescribing. So in some, it's better to avoid such kind of polytherapies. And for this reason, recently there are a lot of developments in terms of helps, aids to the clinicians. One very useful is this NBN. NBN is a project that aims to help the clinician by defining the specific profile of each of the compounds that we are using every day. And moreover, this can be easily downloaded for our smartphone. And actually, I'm using it in clinical practice, and it's quite useful. You can start from the efficacy that you need, from the tolerability, if you want to avoid specific side effects. And so it is quite a flexible tool that I suggest. It is very useful. And so, in conclusion, antipsychotics for depression, indeed, we have new treatments that are coming out. They are already available on many markets. We have new possibilities for treating depression, both bipolar depression and major depression. But we have to be careful in selecting the subjects for each specific compound. In the future, we will have support from genetics. And as an example, this talk is not on genetics, but as an example, this is a paper that is not published yet from our group where we see that a specific genetic profile may suggest the use of antipsychotics compared to antidepressants or mood stabilizers. So in the future, this information will be very useful, but it is still in the domain of research up to now. If you are interested in seeing more details about the genetic or also this presentation, you can check in my YouTube channel where specific videos are there uploaded and freely available. And finally, I would like to thank all my collaborators that are working very hard to try to study and improve our knowledge. Thank you for your attention.